we continue our discussion of physiologic effects of chronic renal failure, includes the cardiovascular system. Eventually you get hypertension, which can cause a very vicious cycle due to the activation of the renin-angiotensin system due to renal failure. You also get advanced coronary artery disease with cardiomyopathy developing and an increased risk of developing strokes. Patients will also develop increased incidence of fluid overload with the development of congestive heart failure. Very oftentimes, with chronic renal failure, you'll develop uremic pericarditis, which is an effusion with possible tamponade, and commonly seen with arrhythmias that are very significant. The angiotensin angiotensin 2 is increased dramatically in chronic renal failure as these individuals develop increased production of renin and secrete due to decreased perfusion. This leads to an increase in angiotensin 2, which then can cause an increase in sympathetic activity. It can also increase tubular reabsorption of sodium, chloride, and potassium, which will then make the potassium hyperkalemia situation significantly worse. So overall, you'll see significant effects on their angiotensin 2 levels in patients with chronic renal failure. Treatment should be aggressively treat the underlying cause. Check your glycosylated hemoglobin levels for diabetic patients. Pharmacological treatments include ACE inhibitors for treatment of hypertension. You can also consider in type 2 diabetics with chronic renal failure and proteinuria. Angiotensin receptor blockers seem to be a preferred choice. The other thing they can have is beta blockers in patients that are not in active congestive heart failure as they decrease cardiac events and may prevent some remodeling that occurs due to progressive hypertension. Renal replacement may eventually be needed in these individuals, including transplantation, and as interim bridge can be dialysis or long-term therapy include hemodialysis or peritoneal dialysis. All the ACE inhibitors which you'll encounter during a clinical all end in PRIL, P-R-I-L. And of course, they have much more complicated, not generic names, but they brand names. Just know that we tend to test you only on generic names. So all you have to do is look for an ACE inhibitor, is look for the PRIL ending to indicate to you that it is a ACE inhibitor. The ACE angiotensin receptor blockers, on the other hand, they end in the wording sartan, which is selective arterial angiotensin blocker. So all these agents are by generic name losartan, valsartan, are basically block the angiotensin 2 from binding to the angiotensin 1 receptor. So they still allow for the angiotensin 2 to bind to angiotensin 2 receptors, which cause vasodilation. So in that sense, it helps with decreasing blood pressure in that individual. Angiotensin receptor blockers seem to be a lot more potent than ACE inhibitors and have significant problems intraoperatively in their management. Sometimes these people can be very difficult to manage, and they develop significant hypotension during anesthetic cases. Hemodialysis is the actual treatment of chronic renal failure. The annual mortality rate of somebody on hemodialysis is around 25%. The complications from hemodialysis are very common, including hypotension due to volume depletion, osmolar shifts. Patients may also develop myocardial ischemia. They also may get dysrhythmias from rapid electrolyte changes, and may also develop chronically pericardial effusions with tamponade. The patients may also develop hypersensitivity to ethylene oxide, which is a sterilizer of the hemodialysis equipment. They may also have sensitivity to polyacryl nitrile, which is an ACE inhibitor. The patients become more sensitive, generates bradykinins and peripheral vasodilation. So clinically important, if patient arrives post-dialysis and is hypotensive, it could be that their hypersensitivity to these agents. Nutrition and fluids, loss of lean body mass is very common in patients on chronic renal failure. They tend to get coarse chronic fluid retention, which is one of the indications for hemodialysis. They get whole body potassium depletion, and as a consequence tolerate high serum potassiums a little better. Water-soluble vitamins are removed by dialysis, unfortunately. So the 9 water-soluble vitamins, including B1, B2, B3, all the way to B12 and C. Then you also thiamine, riboflavin, niacin, all those agents are all basically removed by dialysis. On the other hand, your ADEC, which is your fat-soluble vitamins such as vitamin A, D, E, and K, are not really affected by hemodialysis. Cardiovascular disease accounts for 50% of deaths. Patients with hemodialysis, especially ischemic heart disease, is caused by elevations in hypertension and elevations in cholesterol. Patients also have an increased development of hyperhomocystinemia, which accelerates atherosclerosis. It can also be exacerbated by anemia that's just chronic in these individuals. They get periodic hypotension during dialysis and impaired oxygen delivery from uremic toxins. Patients often develop congestive heart failure from fluid overload, hypertensive constrictive myocarditis, and pericarditis may develop. Hypertension with fluid retention is an essential. Hypertension may be a long-standing problem with hemodialysis, which increases their risk of disease. And pericarditis with effusions are something that are commonly seen, which vary high volumes because of the long compensatory time that these people have developed. Coagulopathy is another problem with chronic renal failure patients that are on hemodialysis. This is due to altered platelet function, which may be partly responsible by DDAVP. And then you may also see heparin in free dialysis, which is helpful, but a lot of times you do give these people heparin, which increases the risk of coagulation problems. Infection-wise, there's an increased rate of infections because the body's immune system is not as robust. There's impaired phagocytosis and chemotaxis as a consequence to uremic problems. They also have impaired immune response. So fevers are very unreliable as indicators of infection. TB is actually very common. These individuals may have actually a negative SIN test. Pneumococcus and hepatitis B and C are also common problems. Peritoneal dialysis is another form of dialysis that's a little bit less invasive in the sense that it's not as causing as much fluid shifts that are taking place. It does not require vascular access. Instead, it uses the peritoneal lavage method. It's still a surgical treatment that requires general anesthesia to get this in place. The complications of it, of course, are things like peritonitis or in formation of adhesions with possible bowel obstructions as a cause. Now, what happens when you have with drugs when you have dialysis? The dialysis clearance is basically dependent on the degree of protein binding. Low protein binding, the better. Water solubility, the more water soluble, the better in the sense of drug clearance. And low molecular weight molecules are usually drug cleared through dialysis than normal. Anesthetic management in patients with chronic renal failure. Preoperative evaluation of the patient should be optimized, and should we really stop some medications? The question is, most of the time we try to stop our angiotensin receptor blockers. ACE inhibitors is controversial depending on where you're working at. You have to ask. Induction-wise, what to give and avoid is a consideration. Maintenance, which agent should you give or avoid, and postoperative management are going to be discussed. Preoperatively, pre-op versus post-op dialysis. Well, most of us will say that you should do somebody and have them having dialysis before you have surgery. That way you get most of your uremic toxins out. You also will get the person a little bit less volume and get their potassium under better control before you start the case. Please be careful when you do dialysis before cases to make sure that you check your electrolytes just prior to surgery, because there's still significant shifting taking place for the next several hours as a person re-equilibrates after dialysis. If you do it post-operatively dialysis, that's appropriate if you've volume over-resuscitated the patient during the operative procedure. You should need to consider weight as an indicator of volume status, and the patient is hypovolemic, you'll notice that the weight drops significantly in these people. As for anesthesia, prior to surgery, you should keep a very tight glucose control. As you can discussed before, glucose is a pathogenesis of worsening renal failure. So and you want to make sure that your potassium is less than 5.5 milliequivalents per liter. EKG, look for signs of hyperkalemia, dish toxicity, and things like ST segment changes. Beta blockers really should not be stopped, and they're usually not. ACE inhibitors is really questionable risk of intraoperative hypotension. Some centers will actually have stopped because they tend to see more effects of hypotension in these individuals, especially now here in Florida, where patients are already dehydrated in the first place. Angiotensin blockers have significant increases in intraoperative hypotension, so these things should be stopped. So do not let patients have angiotensin receptor blockers and take them to the operating room. One of the things that you see with renal disease is that patients have usually advanced disease, advanced age, which as a consequence have pre-existing renal problems, and then may have to undergo major vascular surgery at increased risk for post-op renal dysfunction. The patients have elevations in CO2, or actually CO2 may be something that you see very common in these individuals because they have metabolic acidosis and the body begins to compensate by increasing bicarb production. Patients often will develop some degree of respiratory compensation for it and may actually see mild hyperventilation taking place. It shifts the oxygen dissociation curve to the left, which makes less oxygen available to tissues. You may also see that patients have decreased thiocyanate, sulfate clearance protects from cyanide toxicity from individuals. Induction and chronic renal failure. Remember that these patients have very often have delayed gastric emptying and may have a need for rapid sequence. Intravenous induction agents are fairly safe, and most of these patients do act as hypovolemic, so you want to sort of preload, give them a little bit extra volume before you start. Succinylcholine is considered safe as long as potassium is below 5.5 and not having any other contraindications that you normally would not use succinylcholine for. One of the things that you do have problems with is over time you have disruptions of the blood-brain barrier, and there's less protein binding, so there's an increase in bioavailability of induction drugs in patients with chronic renal failure. Remember that potassium can be released after succinylcholine by as much as 0.5 to 1 milliequivalent per liter, and it appears that defisculating doses does not really help this situation. But as long as you maintain a 5.5 potassium level or lower, usually it's considered safe. Volatile anesthetics-wise, one of the things you want to have is that it decreases renal blood flow, GFR, and urine output by causing a drop in blood pressure and cardiac output, which can be transient. Remember that painful stimulation also increases antidiuretic hormone secretion, which retains more fluids, and that also positive pressure ventilation also decreases your A2 natriuretic peptide secretion, and increases your fluid retention as a consequence. Things that you have to watch for in patients with renal disease is that sevoflurane is metabolized to fluorinated compounds, and that fluoride, if you get it greater than 50 millimoles per liter, is not necessarily a good indicator, but you may see a transient tubular dysfunction and you see loss of concentrating ability by the kidney. And one of the things you'll see is that the fluoride toxicity will cause proximal tubular damage, and then you'll see an increased level of enzyme spillage of things like N-acetyl beta-glucosaminidase. You may not see really a change in creatinine or BUN, and the really measurement of compound A is really a questionable significance. When you combine nitrous isoflurane or dustflurane provides sufficient potency to decrease pain and its ability to decrease the dosage of neuromuscular blocker. And excessive cardiac depression may actually occur with these agents, but usually with combining the nitrous and with it, you have less of an effect. Narcotics may be helpful, but they may have less cardiac depressive effects, but may have prolonged action in nephric patients that cannot secrete these molecules into the urine. As for neuromuscular blockers, you have slowed clearance of venosteroidals such as vecuronium and rocuronium. What we tend to use is benzoisoquinolones, as these drugs are broken down by different pathways. Atracurium and cisatracurium are broken down via Hoffman degradation. The problem is that the byproduct of it is laudanosine, and may actually cause seizures in some individuals. But this is on high doses. That's something you wouldn't have to consider during the operation under normal circumstances. These would be mostly ICU management problems. You may want to decrease your initial dose. The clearance of neostigmine foam is actually slightly slowed in these individuals, and the risk of recurrization is small, and maybe have other causes such as aminoglycoside therapy or other kinds of medications given to these patients. Fluid management, hypovolemia is the #1 cause of low urine output in most individuals. Intraoperative urine output is not predictive of post-op renal insufficiency, so one thing that I would consider avoiding is mannitol in patients with renal insufficiency already, and avoid lactate ringers or potassium-containing solutions. Stick more to normal saline in these individuals. Consider putting a central line or Swan-Ganz or an A line in these individuals. Surgical stress response is also a pathological process that may affect kidney function hormonally as well as pain-wise. And the other thing you got to watch is watch the fistulas. Patients that are on hemodialysis, make sure that you don't put a blood pressure cuff on that arm. The next thing is renal transplantation. For you do a renal transplant, the individual has to transplant not in where the kidneys are at, but it's actually in the abdominal space, right next to the femoral arteries. The attachment point is by using a branch of the external iliac to connect up to the transplanted kidney. What you see in these individuals is you do rapid sequence induction, because many times they are full stomachs, and you follow the transplant protocol as per the site where you're working at. You want to definitely avoid sevoflurane in these individuals. Watch for hyperkalemia and hypotension on removing the cross clamp, especially if it wasn't washed properly. You want to stick with non-depolarizing agents if you can. Once you get started, such as benzoyl-quinolones, we're more dependent on halpin degradation. And remember that heparization is a critical value as part of the transplant protocol, usually prior to implanting the kidney, to make sure there's no clot that forms inside the new kidney. Postoperative complications is you got to watch for acute rejection. DIC may become part of that rejection process. The development of hematomas from this vascular reanastomosis, sometimes it'll leak. Patients may also develop ATN from prolonged delay between removal of organ to implantation. Alright, let's talk about primary diseases of the kidney. Some of the things that you may encounter with things like glomerulopathies, usually from deposition of antigens or antibody complexes in the glomeruli. This leads to rapid damage and causes hematuria, proteinuria. The patients will develop hypertension, edema, and decrease in creatinine clearance. As for nephrotic syndrome, these individuals have proteinuria greater than 3.5 grams per day. Signs of symptoms they develop is sodium retention and decreased oncotic pressure with the development of edema and hypovolemia. They also form increased risk of thromboembolism. Infection of pneumococcal peritonitis and low IgG levels may also be evident because of loss into the kidney urine, and there's also protein binding effects on drugs. So in nephrotic syndrome, you have altered glomerular permeability and loss of negative charge with increased filtration of plasma proteins, and that means that the proteins spill into the urine. This leads to a loss of transport proteins with decreased vitamin D and decreased thyroxine. It begins to affect your anesthetic agents, as there are some of them that are transported by proteins. Hypoalbuminemia in the blood will lead to edema formation, and the hepatic synthesis of lipoproteins may become a problem where they eventually develop lipiduria. The proteinuria also leads to loss of immunoglobulins, which becomes a problem with immunosuppression. In primary diseases of the kidney, like Goodpasture's disease, you have antibodies against glomerular and alveolar base membranes. This can also affect the lung, where you get an alveolitis. The patients will develop hemoptysis, pretty much like glomerulonephritis in the kidney. The other disease process is interstitial nephritis, which is an allergic reaction, autoimmune infiltrative. The effects impaired concentrating ability, proteinuria, and hypertension. You may also get Alport's disease, which is a hereditary nephritis, where you see it more. It's an X-linked, so males have a much higher predominance than females. Hypertension, renal failure, with hearing loss, ocular impairment. It's usually a collagen 4 deficiency, which weakens the basement membrane, and as a consequence, you get protein and red blood cell loss into the nephrons. The other one that's hereditary is polycystic disease, which is an autosomal dominant disease. Is progressive to concentrating, decreasing concentrating ability, and you may also have central nervous system lesions as well. Fanconi syndrome may also be talked about. Again, Fanconi's anemia. It's a little bit different. Fanconi syndrome is the one that's talking about disrupted proximal tubular function. It leads to hyperamino aciduria, glycosuria, hyperphosphaturia. You get vitamin D resistant rickets in these individuals with a loss of potassium, loss of water, and loss of bicarb. And more commonly involved in here in South Florida is problems with nephrolithiasis. Things like calcium oxalate, the number one cause of stones, are radiopaque, which is good. It's usually caused by hyperparathyroidism, hypercalciuria, hyperoxaluria, or hyperuricasuria. You can also have Sturvite stones, which are radiopaque, that are occurring from chronic urinary tract infections from urea-splitting organisms, specifically protease, Pseudomonas, Klebsiella, Staphylococcus, or Mycoplasma. These patients develop a alkaline urine due to the bacteria, and as a consequence form the Staghorn calculus that can become involved completely inside the kidney. The more rare forms of nephrolithiasis include calcium phosphorus, which is a radiopaque, and leads to renal tubular acidosis. Urate crystals may also be evident as well. It's from gout, hyperuricasuria, uric acid nephropathy. And the last one is cysteine, which is an opaque cystinuria induced. The way you diagnose these individuals is you do either an ultrasound, you can do a urinalysis as well. CT and IV polygramms and CT urographies are all helpful in diagnosing the actual stones inside the ureters. The treatment includes hydration and the consideration of placing urethral stents in place. What a stent basically is we enter through the ureter, enter through the urethra into the bladder, then the catheter, a wire is passed up under radiographic examination into the ureters, and then the stent is placed in to allow drainage of urine. After this treatment, this is usually done for somebody who's infected, has high fever, or is developing evidence of acute renal failure. Once a little bit of time is given, and treatment of removal of stone is the next part. If the stone doesn't clear from the stent being there to help, then the person receives extra corporeal shockwave lithotripsy. This can be included in being immersed in water, or what we tend to do more now is just using just air. Immersion causes venous compression, vasodilation, pulmonary restriction, which is an issue and has a much higher complication rate than using the dry ESWLs. You still can get pulmonary contusions, dysrhythmias, pancreatitis, and shattering of calcified aorta as a very major complication. This is the old way that we used to do it. We used to put these people under general anesthesia and then dump them into the tanks. The other way is that some places would do it is under epidural anesthesia. The problem with it is that you had to make sure that your epidural was done with saline instead of water. Saline instead of air. Any air into the epidural space would actually compound the problem of the shock wave, and it could cause cord damage. So if you ever decide to do these epidurals for patients in these tanks, make sure that you use saline only for your loss resistance. This is the way we tend to do them nowadays. We use the dry bed to fire it, and what the shock waves basically do is it break up the stones. Just got to remember, anything that's calcified inside the body, if the shock wave, it can cause fracturing. So if you have the aorta that's heavily calcified, it can actually cause a complete disruption of the aorta. ESWL by immersion or gel pad contact should be done under general anesthesia most of the time. You can do them under spinal as well, but again, very clearly it's watch epidural if you're using air, as you can cause paralysis. Percutaneous nephrolithotripsy is a new treatment where we actually can put a catheter directly up against the stone and then emit very high shock wave to cause the stone to break up. This is done under general anesthesia usually. Again, just to show you another way, the way it's done. The ultrasound generator touches or contacts the stone, and then it fractures the stone. Now let's talk about prostate problems. Prostate problems can lead to hyperplasia, which eventually leads to urethral obstruction. This causes urine retention and causes severe amount of pain. You can also cause this by the actual direct compression by the gland, which is called static, or it can actually be caused by drugs such as alpha-adrenergic mediated muscle tone factors, which we can do from spinals. We can actually reduce the ability for these sphincters to work properly and dilate. Medical treatment includes things like anti-androgen therapy, or things like alpha-adrenergic blockades, such as terazosin. These agents allow for relaxation of the sphincter and allow for urine to flow properly. The prostate itself is a fairly vascular tissue with a significant amount of prostatic sinuses, so these actual procedures have a high risk for developing bleeding, and that always has to be taken into consideration. Some of this bleeding can be very, very difficult to control because these sinuses are sometimes not very amenable to cautery. When you look at prostatic hypertrophy, the way we deal with it, and especially in the past, was more of a TURP, which is transurethral resection of the prostate, and prostatic stents were placed in the past. We also do laser prostatectomies and the TURP, which we'll talk about in a minute. TURP is transurethral resection of the prostate. Involves using a cautery wire and cutting away the inner portions of the urethra and the prostate interface, and eventually making a new channel for the urine to flow through. We usually do these under regional anesthetic if possible, and if not, under general anesthesia. Spinal anesthesia is really considered the treatment choice because you can actually watch the patient's mental status to make sure that you're not having problems with what's called TURP syndrome. You need to basically cause a sensory supply to urethral prostate, and is covering between S2 to S4, so really it's best treated with a spinal, not an epidural. Sensory supply to the bladders are anywhere between T10 to T12, so you need to achieve around T6 level to get a complete adequate blockade for this kind of procedure. Although even a lower one like a T8, the T10 level still will be adequate. The problem would be is that if its surgeon takes too long a period of time, as the level begins to fall, the patient develops significant symptoms. Regional anesthesia does not abolish the obturator reflex, which causes external rotation and abduction of the thigh, secondary stimulation of the obturator nerve by the electrocautery current. And some surgeons will require us to put them under general anesthesia as a consequence. This reflex is reliably blocked only by muscle paralysis during general anesthesia. Another option is an obturator nerve block using a nerve stimulator, but that may not be the easiest thing to do. What's TURP syndrome? Basically, TURP syndrome is when the patient gets too much exposure to the actual fluid that's being used to be able to visualize the area where they're working, the urologist. Things that the person will develop will be central nervous system dysfunction, such as restlessness, headache, and tachypnea. It may progress into respiratory distress, hypoxemia, pulmonary edema, nausea, vomiting, confusion, and coma. The syndrome has a significant mortality unless it's recognized and treated promptly, and signs will be detected earlier in the awake patients. That's why we tend to want to do these under spinal. A lot of our guys will want us to do these patients under general because of the obturator reflex that I was talking about before. So general anesthesia, the only way you pick up on the problem that you're having is that the person develops tachycardia and hypertension. Diagnosis can be confirmed by low serum sodium levels, which usually fall acutely, less than 120 milliequivalents per liter, and usually always symptomatic. So TERP syndrome occurs because you're using a cautery device that opens up the prostatic sinuses. These prostatic sinuses are very, very large veins that are under low pressure systems that can accept the fluid that you're infusing through into the bladder and into the urethra to clear the field so the surgeon can see where they're cutting. So it could be from high irrigation pressures. One of the things you got to watch for is if the surgeon asks the nurses to increase the height of the irrigation bags, that tends to indicate to you there's a lot more bleeding taking place, and that means there's greater uptake of this fluid. And by increasing the height, he gets better clearance of the visual field. But the problem is also increasing the flow velocity of these irrigants, and as a consequence, you increase absorption. We try to tell our surgeons to maintain it under an hour, so lengthy resections are a bad idea. Usually, if the patient requires more than an hour, they need a two-step procedure. They'll do partial TERP, and then they come back a week later and do it again, or a few weeks later and do it again. Remember, these are hypotonic irrigants, so these tend to cause a significant hyponatremia in these individuals. If these things are taking place where the prostatic sinuses are open, you get irrigation absorption. You get increasing volumes, which causes hypervolemia in the individual, which then causes left ventricular failure. Hypertension and bradycardia may take place. These people may develop cardiovascular collapse if you wait too long. May actually develop pulmonary edema, which causes respiratory failure and death if it's not well managed. The solute changes themselves causes hyponatremia, hypoosmolarity, which increases the incidence of pulmonary edema. One of the things that you also see is that you get an increase in absorption of other compounds that are part of the diluent, which are glycine. Glycine itself converts into ammonia, which may develop encephalopathy, and glycine in high enough levels will actually cause visual changes, including blindness. It's temporary. It may actually also induce seizures. So TERP syndrome is actually something that you really want to watch for. Hypervolemia, absorption of irrigants with leads to hypertension, eventually leading to hypotension, congestive heart failure, bradycardia, pulmonary edema, cyanosis, and hypoxemia. The hyponatremia cannot have the fluids that you're infusing cannot have any salts to decrease conduction. Absorption of sodium-free irritants, such as at least a dilutional hyponatremia as a consequence, which causes the confusion and agitation, and worsens the pulmonary edema and increases the chances of developing cardiovascular collapse and seizures. You avoid quick correction because remember you got to have the problem with central pontine myelinitis. But if you do have the seizure taking place, you do have to rapidly reverse this effect by giving 3% normal saline. Which is just enough to correct it. Usually at that point you better put an A-line and start monitoring the sodium levels very closely. TERP syndrome is hypoosmolarity is a major factor. You get cerebral edema and increasing cranial pressure. Metabolic acidosis is mild, so it's usually not something you have to necessarily treat. Hyperkalemia from RBC hemolysis may be a bad problem as well. You get coagulation problems and dilutional anemias taking place. This is an individual that has a very large prostate in this picture, and this shows you the wire that they use to cut away the prostate. Glycine is another thing that is incorporated into the fluid to give it a better ability to visualize the field. Unfortunately, it converts high levels of glycine converts into glycosylic acid and ammonia. So you get a hyperammonemia in these individuals, which causes nausea, vomiting, coma, and you can reverse it with arginine. You can also develop a hyperglycemia. The glycine is similar, acting as GABA, and it causes visual disturbances up to transient blindness, and causes an inhibitory effect on the retina. It can potentiate NMDA receptor activity such as encephalopathy. Seizures may actually be also as a consequence, and we find that magnesium therapy actually suppresses the NMD receptors. Hyperoxaluria, which is glycine converts into oxalate, and unfortunately, oxalate doesn't really have any toxic effects in the kidney. So to avoid TERP syndrome, you want to limit the duration of surgery. You want to minimize exposure of open venous sinuses. Limit the position of irrigation to maximum 60 centimeters above the surgical field. Limit the extent of bladder distension. And maintain adequate blood pressure, and therefore maintain periprostatic venous pressure in order to avoid intravenous absorption. And then you want to check your neural status very frequently. There's another problem that can happen if you during TERP procedures, and that is bladder perforation, which is about 1% incidence. Perforations occur mostly during difficult resections. Then the guy gets into the bladder and actually cuts open the bladder. It's very difficult to recognize with spinal block. Perforations extra-abdominal leads to painful inguinal, periumbilical, and maximal suprapubic pain. Perforation intraperineal leads to a generalized abdominal pain. You get shoulder pain due to tracking of the fluid up against the diaphragm, and you get also signs of peritonitis. These surgeries go from being straightforward now to become much more complicated. If it's a small perforation, you can treat by urethral catheters in out-of-body coverage, but most of the time these become major perforations and usually required suprapubic cystostomy or formal exploration, repair of the perforation or drainage of the perivesical space. You may also get transient bacteremia and septicemia if the prostate's colonized with bacteria, which harbors chronic infections. TERP facilitates the entry of these bacteria into the bloodstream via open prostatic venous sinuses. So bacteremia following TERP is usually asymptomatic and easily treated with antibiotic combinations against gram-positive and gram-negative bacteria. Some 6 to 7% of patients develop septicemia, and severe cases septic shock with mortality rates as high as 25 to 75% has been observed. In recent years, sepsis was the most common cause of death after TERP syndrome in one of the urological cooperative studies done in 1989. The other thing that can occur with TERP is hypothermia. Inappropriate measures to reduce heat loss are such as warming blankets, heating the irrigated solutions. Unintentional hypothermia is associated with significant higher incidence of postoperative myocardial ischemia, especially with postoperative shivering. It can actually dislodge clots and promote postoperative bleeding.